Well, welcome everyone to this month's FLS Bone Health Echo Tele-Echo Clinic. As you can see by the slide up above, we will be recording the Tele-Echo Clinic for education and quality improvement purposes. I also wanted to mention to have everyone please enter in your email and your name in the chat box so we can make sure to get you CME for this session. As you see on this slide, some helpful tips regarding the FLS Echo to please mute your microphone when not speaking, pay attention to the webcam, and please communicate speaking clearly and using the chat function. The key piece of the FLS Tele-Echo is the back and forth in questions, so please do not hesitate to ask a question, make a comment, either using your microphone or the chat box. Just quickly wanted to review Project Echo's goal is to protect patient privacy and share with you some common HIPAA identifier slip-ups and easy ways to protect patient privacy. Most of you have seen this many times before, so I'm not going to read them, but please take a moment and refresh your memory on the 5 items we have above. It's my pleasure to be able to invite our speaker, Dr. Avery Jackson, to present today for our 10-minute didactic. I'm going to turn it over to him. And just one note, once again, in terms of questions and comments, to please keep those going, and that we will have case presentation after Dr. Jackson's presentation. Dr. Jackson?
Okay, thank you, Debbie, for inviting me. Thank you all, NOF and NBHA. I'm Avery Jackson, a neurosurgeon, and been a part of the National Osteoporosis Foundation's efforts now. Also, we have an MI Great Lakes Echo, which was founded in 2017. So I really appreciate the richness of your program and what it entails. So I was asked to have a discussion about the FLS and kind of using a different or having discussion from a different lens as it relates to FLS strategies for growth. And so in my practice as a neurosurgeon, we perform vertebral augmentation. And so my perspective of FLS and of osteoporosis is just slightly different. Just in the sense that the initial encounter oftentimes is from the standpoint of vertebral compression fracture, and then the standard FLS as guided by the National Osteoporosis Foundation guidelines. And so one of the questions that was the overarching question in the surgical practice was, does an FLS program minimize recurrent vertebral compression fractures? And so we're going to take you through a very quick 10-minute journey or 8-minute journey of the experience here at MI Great Lakes Echo and some challenges that we faced as a neurosurgical practice, and maybe a couple of pointers that might be helpful to you that we can impart along the way that we've picked up over the last 4 years or so. Next slide, please. And so here are my disclosures. And also, Deb, if you wouldn't mind hitting slideshow, if you could. Great, and that'd be great, thanks. Okay, next slide. And so our discussion objectives today are going to be looking at implementing an FLS program in the neurospine setting, evaluating new and emerging strategies, or at least one strategy for FLS growth in challenging practice settings. And then to kind of round it out with what's very relevant and germane to this practice, and I believe may be helpful to other practices across the country, and that is reduction in refracture rates post-FLS implementation. Next slide. So when we look at implementing an FLS program in the neurosurgical spine practice, we can broaden this discussion to even in a neuroradiology or interventional radiology practice or orthopedic practice, of course. My practice is a neurosurgical practice. It's a private practice, been in practice for 18 years, performing vertebral augmentation during that time. And when we perform vertebral augmentation prior to FLS, we would perform the procedure as indicated, send the patients back to the PCPs, you know, the referring physician, for osteoporosis management as needed. But we started to begin to see an increasing number of return patients who had further fractures. And so we took a hard look at this and said, well, let's do some homework. Next slide, please. And next slide. Thanks. And so we did some homework and noted that one of the orthopedic surgeons in our state had a mature fracture liaison service that was up and running, and they treated fractures similar to my practice. So we had the coordinator come down to the practice and speak with us on FLS, which again was a new concept to us at that time, and we readily embraced the FLS. We went to the National Osteoporosis Foundation's ISO meeting and became certified with the intent of decreasing the continued fractures that we were seeing and being able to add to our armamentarium both the surgical treatment of these fractures of the spine, but also, and more importantly, the preventative side of these fracture management. Next slide, please. I'm sorry, Deb, next slide, or Andrea. Thanks. So, yep, next slide. Okay, and one more slide. So, just like any other FLS, we initially began in a specific format by going to the hospital and the community physicians and saying, look, this is a problem in our area just like it is across the country, and we really need to implement this FLS so that we can improve the lives of the patients that we're serving through a unified FLS program and concept. And we had some pushback on the hospital side, but also on the PHO side in our community, about 200 physicians in the area. And so we were educating them. We sat on many committees. We were able to make some headway regarding creating algorithms that are now on our EMR as it relates to primary diagnosis and management, but not post-fracture care. So we joined Own the Bone and that registry for fracture care. So we initiated the FLS in our office and said, well, how can we as a clinic continue to maintain the fracture liaison service and still attempt to be a beacon of light to those patients who aren't getting the coordinated care of FLS and best practice. Next slide. And so one of the things that we noted was, as opposed to kind of using kind of the standard model as a business model and presenting that model to the hospital and to the PHO, we said, well, what resources do we have and what are we doing in our own practice? And so as a surgical practice, we noted that we were taking care of the fracture patients. So how can we use the fracture or surgical language to demonstrate the utility of FLS and the improved outcomes of the standard FLS protocols in this patient population? So here's a study that we have in our office that's it's ongoing and will be published later this year. It was a retrospective analysis comparing pre-FLS patients that we saw in the office from 2012 through 2014, being Group A, and the post-FLS patients, if you will, and that is to say from 2015 through 16, the patients that we saw after being certified as an FLS and implementing what we learned from the ISO meeting and the formal certification of FLS. All of these patients were surgical candidates and all had vertebral compression fractures. Next slide, please. Here is just a brief slide that I lifted from John Carey's slide deck just recently. And just to point out, as we're speaking about compression fractures in particular, that the prognosis or vertebral fractures predict future fractures independent of bone density. Obviously, when bone density is low and there's fracture, you're going to have a worse prognosis and higher risk of recurrent fractures, as Ross presents here in this slide. Next slide, please. So here in our pre-FLS group, we had 172 patients in group A, and this is the pre-FLS group, if you will. They were all fracture patients treated in the standard fashion. You can see the comorbidities and calcium, vitamin D levels here, DEXA scores average. And then importantly, camping on the refracture rate that you see here of 54%, and then the FRAC score. Next slide, please. And now if you take a look at the post-FLS group, we have 199 patients. As you can see, the breakdown, comorbidities, and calcium, vitamin D for some statistics and demographics here, the average DEXA scores. And now take a look at the refracture rates post-FLS. So the refracture rate going from being in the 50% to now 36% was statistically significant. And so next slide, please. And so the point here is that this is kind of a unique view at looking at FLS and its utility, not only from the standpoint of decreasing fracture rates in standard fracture management, best practice, through the FLS model of care for these patients, but also there's an opportunity here as we're speaking about supporting the FLS concept in terms of obtaining funding for this FLS and to make sure that we can fund the FLS with the appropriate providers as well. And so this is a unique opportunity in implementing the FLS program, again, from a neurosurgical standpoint in terms of fracture management. And we've used this, what you've seen here just briefly in a short amount of time, just to kind of illustrate that in a very tenacious environment, we've actually done very well and we're continuing to grow. And we're squarely focused on decreasing the refracture rates of these patients in both spine, hip, and distal radius. And so we've been able to demonstrate in the most recent look at our patients comparing pre and post FLS experience that we're heading in the right direction regarding refracture rates. So, so that's really the end of my talk. And again, I wanted to be brief. Deb said that you had a couple of cases, and if there are any questions that I could field, I'd be happy to do so.
Great, thank you. That was a wonderful presentation. Before we go to any questions, just a quick reminder to please enter your email and your name for CME. And we are open for questions. Does anyone have any questions they want to ask Dr. Jackson about his presentation or addressing any of the barriers or questions that you've come upon around implementation of FLS? You can speak out or post your question in the chat box. So one of the questions is regarding which areas of your hospital did you have to build relationships with in order to implement the FLS, or did you just sort of go ahead and implement and show the value of it and go from there?
So that's a great question. So what we initially did, of course, is in my private practice clinic setting, we initiated the standard FLS protocol with our patients. We signed up with the NBHA, PQRS at the time, as well as the Own the Bone registry, so that we had a benchmark and metrics that we could follow. And then from there, we reached out to the two groups in our region. The first group is going to be the executive leadership at the hospital level in our region. It's a 410-bed level 2 trauma center. And we talked to the leaders and said, listen, here's a major problem. Here's the raw numbers that we're seeing, and only 20% being managed, as you're well aware of. And so they said, well, okay, well, why don't you show it to us, right? So we looked at the number of patients that were coming through the emergency room in consultation and how many people were being missed, and created a committee on the hospital side. And sure enough, after a 2-year look roughly at the numbers and the number of patients that we were not diagnosing, it was about 80%. Then we went to the PHO side and sat on some committees, osteoporosis committees, and talked about ways to work together on the community side as specialists, as the PCPs, as a family practice and other providers, NPs and PAs, and how can we work together to form an FLS program, which is, by the way, as most of you may know, how pretty much all FLS programs were formed. Most of those programs, even going back to Rick Dell and others, and I'm sure that Tom and others would know better than myself, but you know, being in a clinician of some sort says, hey, here's a problem here, let's initiate, do what we can do, and then let's get the hospital involved, our colleagues, and work together. And so we attempted that also on the PHO side, and we made some headway. But where we kind of got stuck was in the post-fracture care and what pathway to take. And so that's when we continued to forge ahead and demonstrate that, in fact, FLS is making a difference in these patients, even with post-fracture care.
Great, thank you. Okay, it looks like we have some other questions. The next one is, how did you gather your data, refracture rates? For instance, if patients were seen elsewhere, oops, I'm sorry, someone sent in a question and moved it down, right? So for example, if patients were seen elsewhere for later fracture care, did you pull insurance data? Let me know, Dr. Jackson, if that makes sense or if I should reread it.
Yeah, and so we actually looked at all of the patients came through from the hospital to to the private practice. So we had all of the data in-house. We had the research, a separate entity, which is the research group, look at our data, along with the trauma surgery group, look at our data, and we were able to cull the data because it was local. Yes, go ahead, and Karen can make a comment too on that, because she's helping with the project.
Yeah, just as far as the refracture rates, we look specifically at our clinic, and because Dr. Jackson treats vertebral compression fractures with vertebral augmentation, that's where we would see the refracture rates for these patients, ones that would, come back needing another procedure. So I'm sure there were some patients that we didn't see their refracture rate, because there were a few patients, part of the refracture rate was based on patients that decided not to follow up with the FLS program, or just, move to a different hospital system, or, we didn't see them again. They were lost to follow up. So there were a few stragglers that I know we, probably didn't get that information on, but I think that makes a difference in our practice, because you're treating, spinal fractures. And so it's patients that we saw again for treatment, if that makes sense.
Okay, thank you. Please keep sending these questions in. They're great. So the next question is, how have you adapted your FLS program to address the opioid epidemic?
Great question. I'm so glad you asked that question. I mean, so we have both an FLS, obviously. We have a bone health echo, as you know, and we have an addiction medicine echo. And what we're seeing is our discussions in the bone health world is intersecting with the addiction medicine world in terms of cases that we're seeing of patients who were treated with opioids early on, not definitive treatment when indicated with procedure, and go on to develop tolerances, and now land in the addiction medicine bucket or both buckets. And so we're addressing some of these patients in kind of both of our echoes and having discussions with the other team members, endocrinology, ortho, and neurosurgery, of course, and addiction medicine specialists. So it's an ongoing discussion that for us is relatively new over the last roughly 6 months or so. So some of those patients are referred to our addiction medicine specialists within our addiction medicine echo, and also some of the chronic pain specialists that are a part of our addiction medicine echo.
Great. Our next question is, we have an FLS at Denver Health and are just beginning to build a registry in collaboration with endo, rheum, ortho, ED, and geriatrics. Do you have a registry, and what are the key data that you include?
So, okay, regarding registry, I just mentioned earlier that the NBHA, they've been working on their certified registry, and we've been a part of the work through the NBHA and NOF in their efforts for our non-fracture patients, osteoporotic patients. We've been a part of the On the Bone National Registry for our post-fracture patients. We've been a part of the North American Spine Society's registry, which includes, all comers in spine, as well as the Michigan Spine Surgery Improvement Collaborative Registry, which is kind of one of the largest registries in the country and dealing with spine. As it relates to the osteoporosis patients in particular, the NBHA and the On the Bone registries are the one where we're able to mine the most data. And so the metrics are standard metrics that include basic demographics, looking at smoking, counseling and cessation, looking at the vitamin D and calcium counseling, as well as steps to make changes there, and looking at diet, and looking at follow-up and the educational components would be some of the metrics that we've looked at.
Great. I just want to open it up before reading the next question to see if other people had any questions or comments. Feel free to unmute your mic and ask your question, or send it in through the group chat. The other question that I see is around patient identification with vertebral compression fractures, and whether you are tied in with that aspect at all, or whether you are really focused in on the patients that you're treating and then making sure that they're engaged in FLS for follow-up care.
Right. So we're clearly focused on the patients that we're treating, but we've reached out to the community, both the hospital side as well as the community providers, as well as other hospital systems in Michigan. So we've reached out to systems north of us, as well as systems that are south. And we've had a fair amount of interaction, both as on FLS, encouraging other systems to develop an FLS program, as well as Bone Health Echo encouraging systems as well to join up with us or develop their own program as well. And so we've done both. And so in terms of, it's been an educational effort, and But again, always reaching out outside of our walls as we grow. And then, for instance, Dr. Illustration is Dr. Waspy. You may have, if you've been on any of our echoes, he's a trauma surgeon, general surgeon that's here in the health system, and he's become a champion for the fracture identification and management through the emergency room and then onto the floor, and has been so enamored with the data, and he's seen such a disparity. It's been so disparate as it relates to management and diagnosis that he's really spearheaded some of the research that we're doing, although he's not part of my practice in any way. And so I think the key here is just collaborative work.
Great. I see 2 other questions. What are the most frequently prescribed osteoporosis treatments in your practice?
So I guess the clarification, in terms of the most frequent osteoporosis treatments. So I'll say procedural, obviously for the patients who meet the specific appropriateness criteria, and they're symptomatic. We identify the obvious fracture that's failed non-operative care. For those patients, we'll perform vertebral augmentation, and usually with a balloon kyphoplasty. On the medicinal side, and of course, that's after addressing all of the other obvious issues, the calcium, vitamin D, lifestyle changes, physical therapy, and so forth, is we're quick to go to anabolic whenever we can, because these are post-fracture patients.
Great, and let's see, I guess this is our last question before we'll switch over to our case studies, is how have you leveraged vertebral augmentation success stories? Do you find that the data on success rates is shared across bone specialties?
Right, and I think that's a very important point that you bring up in terms of the success stories. And yes, we have. We've presented some real success stories of patients who had fractures that were missed in the emergency room multiple times, and patients going on to be debilitated, and then they're treated, and we've seen them become much more active. We've had stories of patients who had pulmonary dysfunction, and those were treated, and improvement in pulmonary function, which is a huge piece that people oftentimes don't think about. They think about the kyphoplasty as more of a pain management type treatment, but we know that there's a lot to do with sagittal balance and pulmonary dysfunction that occurs. For every level that you have a compression in the thoracic spine, you lose about 9% of your forced vital capacity. So we had some really good success stories that have really stuck with both the execs in the hospital side as well as on the community side, in working with the physical therapist and our endocrinologists, our orthopedic colleagues, and others. So those success stories are very meaningful.
Great. Well, thank you, Dr. Jackson. I hope you'll be able to stay on as we present the case studies. Love to have your input. And just to throw out to the whole group, if other questions come up, for Dr. Jackson during this session, please do not hesitate to ask via the chat room.